All right, so what I want to speak about today is something that is being funded. It's a study being funded by Synchrony, and it's a treatment study. As many of you may know, my interest has been over the past many years in treating bowel inflammation that is unique in children with autism. So Dr. Walker and I, Walker is a bench scientist, a molecular biologist, a Wake Forest professor, a very distinguished professor, I should add. And him and I have collaborated now over many years. And the past number of years, we've decided that we first want to describe and characterize the bowel inflammation in children with autism, meaning kids with ASD who have GI symptoms, who undergo colonoscopy and a biopsy. We'll show you all those slides momentarily. And there's inflammation over there. We'll tell you what that is momentarily as well. And they are treated. Now, we know that anecdotally, when we treat them, their GI symptoms get better. A lot of their ASD features get better. But that's never been shown in an academic fashion, and that really needs to be. So that's what we are doing now. I wanted to review that study with you to show that there is work. You've heard a lot over this past over today about a lot of various aspects of the work being done, and sometimes even I find it hard to relate to the biochemical pathways and where it all ends up. And one thing I see in gastroenterology is that, to me, it seems very simple. You have symptoms; they're well described. Go in there and get a look at it. Everyone can appreciate the appearance of a colon, and if you can't, you will by the end of today. And we treat it and we see what happens. We're running low on time, so I will make this brief. But this is a slide of numerous studies that have been published over the past number of years that link autism and GI symptoms, and of course, those you've heard all about. These are linking autism with GI symptoms. GI symptoms are vomiting, diarrhea, constipation, abdominal pain. Those are not diagnoses. There are lots of things that can cause vomiting. You heard a moment before about cyclic vomiting from Dr. Bowles. That's cause of vomiting. Other causes of vomiting could be esophageal disease, acid peptic disease. There could be partial obstructions, mechanical things, infections. There are so many things that can cause it. So when we hear about association of autism with GI symptoms, that's of course very important, but the next question that has to be answered is, what is the diagnosis? What is causing those symptoms? Are 90% of ASD kids with GI symptoms having the same underlying problem? Is it an infection? Is it inflammation? Or is it a scatter plot of everything I mentioned before, plus 25 other potential diagnoses? So those papers that I just went through quickly, those will link behaviors with GI symptoms. What I'm interested in doing is linking the behaviors with a specific diagnosis. The one that I found in my experience is the most common thing we find when we perform endoscopy and biopsy on children with chronic GI symptoms who have autism. As far as the frequency, this Autism-Associated Enterocolitis occurs in almost 3/4 of patients with ASD. We call it Autism-Associated Enterocolitis because it's an inflammation of the intestine that is specifically related to having autism. It's a unique inflammation. The types of cells, the molecules they produce, are different than types of cells and molecules those cells produce in Crohn's disease or in ulcerative colitis or an infectious enterocolitis. This is an inflammation. Cell types, cell subtypes, and the cell molecular products are unique. They occur only in children who also have the behavioral features of autism, and that, of course, is fascinating. That suggests that, in general, being autistic and having those definitive behaviors and cognitive changes is related to unique markers in the GI, in the inflamed GI tract that are only found when you also have autism. And this enterocolitis it's an autoimmune disease. It's not a food allergy. It's not dysbiotic flora. Those contribute to it. The upstream event, which you've heard a lot about over the weekend, is most often in the IBD and an autoimmune event. So what do I find when I do endoscopy, an upper endoscopy in children with ASD? Well, what you're seeing I'll use this slide. What you're seeing over here is the stomach, and it's a bit hard to see, but you can see this is the pylorus. This is where the slope is in the stomach. You're looking through this hole is the entrance into the duodenum. This area around the hole, the pylorus, is called the antrum, and this area is very often inflamed. That's a gastritis. When you pop through that hole, you'll be in the duodenum, and here you see a marked lymphoid hyperplasia, enlargement of lymph nodes, which is not the same as inflammation, but it is one of the hallmarks of the inflammatory bowel disease. This is duodenitis. Here you're seeing actual ulcers of the duodenum. So these are visual markers that we see when we perform upper endoscopy. They're not specific to children with autism. You'll find those same changes in a whole host of other diagnoses in children without autism. That, of course, presents the problem. This is a photograph of the colon during colonoscopy. What you normally should see is pink mucosa with vasculature. Here you see it's not pink, it's a light or dark red. You see an absence of those vascular markings. On biopsy, using the traditional stain that we've been using for well over a century now, what you'll see is that the area over here has a more concentrated cluster of purple stains than what you see over here. Those purple stains are cell nuclei, and this is patchy inflammation, meaning that this is a patch of colon that has an excessive amount of cells, more so than the normal amount of cells that should be there. That is the definition of colitis. Or that is a definition, the most commonly used clinical definition of colitis. This is what this would look like on the pill cam, on the capsule, and it's hard to see at the size of these images, but you have areas of patchy redness. Here you see two discrete ulcerations. Here you see an ulceration. This is a biopsy of the ileum. Here you see these purple nuclei infiltrating what would otherwise be a normal crypt without any cells infiltrating it. That's called an ileitis. And again, none of those are unique or specific for children with autism, but when you then go further and look at the subtype of those little purple dots, you look at the molecules that are present in that biopsy that are produced by those cells and the molecules in the blood, those are unique for children with autism. So what are the symptoms of patients who have that? Patients who come in with autism and come in and have those findings. What makes me want to perform an endoscopy and colonoscopy are the most their GI symptoms. And again, this didn't translate well, as seems to be the pattern. I have to buy a Mac and make up my slides on a Mac. That's the lesson, I think, from the conference. But the stool descriptors, what we call them, the frequency of the stool, texture of the stool, the color, the odor, the volume. We have photographs of all these. Those are different. The frequency of bowel movements in children with autism is 1 to 2 a day, which is normal. The texture is abnormal. It's a loose, unformed texture, not watery. The loose color is typically yellow or very, very light brown. The odor is awful. The volume is often quite large, usually quite large. Bowel movement descriptors is another category, meaning aside from describing the stool, we also describe the bowel movement itself. That's something that no current questionnaires really address. These kids, when they have bowel movements, they're straining. They're not communicating to you at their straining, but they'll do different posturing while they're having a bowel movement. They spend a lot of time trying to get it out. They turn red, their neck veins pop out. They'll bend forward, they'll contort sideways. These are all ways that we know that this nonverbal child who says, I can't poop, is having a problem passing stools. And then you have physical GI signs. Signs meaning what I see, what I as the observer see that's wrong with the patient, not relying on what they tell me, since these kids usually tell you very little or nothing. Abdominal distension, muscle wasting. Then they have, of course, these are all GI-related signs and symptoms and abnormal stools. And then on the other hand, what we want to try and correlate with that in the study is their cognitive and social delays, behaviors, that should be quote-unquote behaviors, aggression, self-injury, hyperactivity, irritability. These are things that, of course, you all experience every day, which may or may not be a GI symptom. Very often it is. How do you know? How do you know if it is? And behaviors of this actually is also a continuation: heightened anxiety, depression, rigid compulsions, and of course, poor sleep. So the question is, when we have a patient with those presenting GI symptoms and abnormalities, we have a patient that comes in with those symptoms, with that kind of stool that smells bad, or abdominal distension, or difficulty pooping, or pooping every 7 days, or light yellow stool, undigested food, abdominal distension, wasted appearance. You look at him and you see his ribs, you see his scapula, the rib, the elbows, hips coming out. Perform an endoscopy on them, you get results that look like the ones we saw on the slide. So now you want to treat it. You want to treat the intestinal inflammation in an effort to get rid of their GI symptoms. So that approach and all those steps are the same as you would do with any child, autistic or not. You define the symptoms, define the diagnosis, and you treat it for inflammation. For bowel inflammation, there is a set protocol that we use to treat. And the question then becomes, for this study, does treating the ASD-associated inflammatory bowel disease, does that help the GI symptoms? Do the stools normalize? Does the distension go away? Do they have no more difficulty pooping? Do they start gaining weight? And also, when you see improvement or resolution of GI symptoms, does that result in improvement of cognition and behavior? And these are things that we know the answer to be yes to both of them, but now we need to show it. The impact of the study is that proof of this, knowing that treating the bowel inflammation does result in GI symptom improvement and cognitive behavioral improvement, that would provide you with one more thing you can do for your child with ASD. It's another intervention. Dr. Rossignol has shown you during the course of the weekend an incredible list he's compiled of all the various treatment options that are published, and he's rated them as far as the quality of the study, the quality of the data. And yet there are no studies that exist yet that describe treating the GI disease. That will be one more very important addition to that already important list. Design of the study, we can actually, so basically you confirm that there's histologic inflammation. Treatment is typically, what I've learned over the years, is that when I do see biopsies like that in this type of symptom situation in autism, is to give it an initial course of corticosteroids, followed by a drug, non-steroidal anti-inflammatory. And that is how we typically treat Crohn's disease or other IBDs. Many people are afraid to hear the word steroids. What your children have is a serious disease. They have autism. It affects the very essence of who they are. There is no more serious disease than that. There really isn't. And if any disease ever deserves a course of steroids to see if it will help, it's autism. So don't be afraid. Don't be afraid of using it. There are much worse things. Parents seem to have no problem putting their kids on risperidone for autism, yet they're afraid of steroids, and I never understood that. But Don't be afraid. Study design. So at baseline, right, we first want to, of course, measure their level of cognitive function and of cognitive function, also many of their behaviors. Many of the behaviors that are typically thought of to be ASD behaviors. And then we designed a new questionnaire specifically for this study, and we called it the GI Symptom Bowel Movement Chart, meaning specific questions, and I'll show you examples of them that directly address the events of the bowel movement. There is no questionnaire that does that, because we know from experience that kids with ASD and this disease have these types of interesting bowel movements. Many of the behaviors that accompany the bowel movements are perhaps unique to them, and certainly very descriptive of what you see every day. That should be included in the parent questionnaire. And those are the internalizing behaviors. And of course, the bowel movement chart itself, or that's the looseness of the stool, the odor of the stool. Typically in a questionnaire, a GI questionnaire that we use for academic purposes, the question is, do you have diarrhea? Do you have constipation? There are 60 people in this room, 70, whatever. If I asked each of you for a definition of diarrhea, I would get 60, 70 different answers. So it's important, especially when you're dealing with a diarrhea that seems to be this one type of stool that most of the kids have. You want to zero in on that and ask specifically about that. This is a summary of what I just told you. So these are the kind of questions we have, some of the questions on the questionnaire. As far as the bowel movement chart, what descriptors of the bowel movement do we ask about? Does the child bend forward when they have bowel movement? That's a sign. It's a Valsalva maneuver. You're increasing your intra-abdominal pressure to push something out, because your normal motility doesn't accomplish that. While the bowel movement is occurring, as they're screaming, stomping, hitting the walls, contorting on the seat, standing, squatting on toilet seat, something that I see a lot of. Any of you in the room have children that stand on the seat and squat that have bowel movements? Don't be ashamed to raise your hand. No one that ever had that before happen. Okay, one. Thank you. It's a way that these children very creatively come up with their own way of having the Valsalva maneuver. Is the grunting? Did the neck veins pop out? Is there facial grimacing? Because if you ask the question simply, does your child have difficulty passing stools, parents may not think about those things that they're seeing every day, because they're accustomed to seeing this is my child's bowel movement. They realize it's something abnormal. Hyperactivity prior to the stool, calmness after passing the stool, undigested food. And now this is the bowel movement itself, undigested food in the stool, the odor of the stool. Odor of the stool is very interesting. That's for another time, but the four types that we hear the most of, there's a rotting, decay type of, rotting or decay type smell, a chemical smell like ammonia or a mothball smell. And we'll get into maybe another time, other reasons why stools would smell that way. In other things back to the bowel movements themselves, the days per week that multiple stools were passed, the days per week that the child tried to pass a stool but was unsuccessful. Common symptom we hear: a child goes to the bathroom, sits down, nothing comes out, they walk out, they go back, they walk out, they go back, and that's a whole process, and it can take an hour or two. So ask specifically about that as opposed to a generalized question: does the child have difficulty passing stool? A parent may not realize that back and forth to the bathroom is because the child has difficulty passing. They just think it's a behavior. Was blood or mucus evident in the stool? We asked about the flatulence, the Bristol Stool Chart. I think you've probably seen over the weekend. There's the stool descriptors. Okay, this is a component of the typical GI questionnaire for a variety of diseases. The color of the stool is not a question you see on typical GI questionnaires. Light yellow, light brown color is something which seems to be strongly indicative of the presence of an inflammatory bowel disease. Oh, I didn't get a chance to fill this slide out. I saw something on the internet very interesting, is that there are people who baked cakes, right? And the cake actually demonstrates the different types of stools. I should have, next year I'll have it for you. If you Google Bristol Stool Chart images, and you'll have a good laugh. So these are some, in interest of save time, I'm going to move through these slides. This is the questionnaire that we have, and as you can see, it's very comprehensive, and it really describes well when parents sit down, and this is online, when parents sit down and do the questionnaire, they're grateful. The best word I can think of. They're grateful that there's a recognition by someone other than themselves that what they're seeing in their house is a problem. They've always thought that this is something that they go through themselves, and it's always interesting to see how excited they are to fill out this questionnaire. Okay, so the hypothesis that patients who are treated for this ASD enterocolitis with anti-inflammatories, there are other medications we often need to use. The hypothesis is that it will, in fact, improve their GI symptoms and behavioral cognition. Why is that the hypothesis? Because we've seen it happen over the years. It's not a guarantee. So the guarantee is that will improve their GI symptoms. That much I can almost guarantee. What that will do to cognition and behavior is always a mystery. We see amazing stories. We see absolute failures, no change at all in the ASD function despite normalization of GI symptoms. Why that's the case? One of the things Dr. Walker and I are working on to see if we can predict from the outset who will be a poor responder, who will be a good responder, because knowing that in advance would allow me to be much more aggressive with those patients whom the biomarkers are those for poor responsiveness. We're looking for the treatment outcome is improvement of GI symptoms first and foremost. That is the primary treatment outcome. And secondary study outcomes would be to see whether the ASD symptoms improve as well, because of course that association, we already know that autism is associated with GI symptoms. What we don't know is that treating the GI symptoms would also improve the autism. So this study would help answer that question. More importantly, I think, in my opinion, is that it would show us, it would prove, it would validate that this questionnaire would develop that these seemingly meaningless, strange behaviors are in fact GI symptoms need to be paid attention to. And that may be the sole indication that your child is having this problem and may benefit from a workup and treatment for this problem. And at the completion of the study, the following questions are going to be answered. Okay, does treating autism with anti-inflammatory drugs, of the autism enterocolitis, with anti-inflammatory drugs, does that improve the GI symptoms? Does that also result in improvement of ASD? Was there a correlation between the degree of GI improvement and the degree of ASD improvement? Is that a linear correlation or not? I think the answer is going to be no. We'll see. Will the externalizing behaviors in fact be manifestations of GI disease or GI symptoms? But I didn't mention on the study design chart because of the translational problem was that the baseline we're taking a blood test, looking for molecular markers of a variety of different things, and at the end of the year of study, we'll also be getting those same markers. And what we'd like to know is that how will if those markers will change, and how will they change? And that's important because those molecular markers may have biologic importance and may give us a clue as to what further we can do to improve their GI disease and their autism. And then, of course, how long to treat. So the study will watch patients over a year, at which point we'll offer the parents the option of stopping the medication, seeing what happens. Those patients who want to continue, of course, will continue for as long as they want. Those patients who opt to stop, and many parents do, there's many parents, I think every parent in this room probably has an inherent fear of pharma and of medications and drugs, and most of you probably feel that your child has been injured by something that we've produced in the pharmaceutical industry. So many parents opt to stop medications after a year, even after having seen improvement. And I'm interested to see what will happen after they stop. Will things get worse again? Thank you very much. That wraps things up.
Thank you.